to talk about holistic assessment of pain tonight, and most of us know that pain is what the patient says hurts. The World Health Organisation suggests that it's an unpleasant sensory, very hard to pronounce after a glass of wine, emotional experience associated with actual and potential tissue damage or described in such damage. Can't hear me, Ingrid? I don't think this is that better? Yes. Okay. I'm just wondering if I can take it out and walk around with it. So that's better? Okay, thanks, Ingrid. When I was about 11, I wrote a composition. In the olden days, one didn't do assignments. You wrote a composition, and I wrote a composition about Albert Schweitzer, who said, "We all must die, but if I can save him from days of torture, that is what I feel is my great and ever new privilege. Pain is a more terrible lord of mankind than even death himself," and I'm sure we're all very well aware of the fear of pain that our patients express. I scribbled under that in a little old autograph book, and I still scribble, by the way, I can't read my writing. One day I will do this. So here we are, a few years later, after I was 11, still doing it. I think it was Teresa Spencer Plain who wrote that the art of caring for the dying, I hate this microphone, is the same as that for all good nursing. What is needed is an acute power of observation, an exquisite sensitivity to the patient's needs, and an infinite capacity for taking pains. We've been working for quite a while, and I'm sure you're all very familiar with the total pain model, the physical aspects of pain, and then the feelings of depression or perhaps dispirited, as I've mentioned to some of you before, the loss of social position, the loss of job and prestige, the loss of role in family, insomnia and chronic fatigue, a sense of helplessness, disfigurement perhaps due to loss of weight or weight gain if we're on steroids or surgery. Many people, when you go into make an assessment, you'll find that they'll look at a photograph that's been taken when they were well, and that's how they prefer you to think of them, not as a patient who's so sick at the moment. The anxiety, the fear of hospital or nursing home, the actual fear of pain, and we've had a few patients lately that have actually been so fearful of what their pain might be that it is a big contributing factor to their pain. Worry about family and finances, the fear of death, spiritual unrest and uncertainty about the future. And just because someone might have a religious or spiritual belief doesn't mean that that necessarily helps them feel more at ease about facing mortality. In fact, it can often compound it because they are worried about what might happen when they die, particularly if they've been brought up in a strict religious background. Perhaps I can mention being Catholic and fear of the devil and hell, etc., rather than a forgiving other being. Anger about bureaucratic bungling, about delays or misdiagnosis, the unavailability of doctors. That doesn't happen to any of the doctors that are here. They're always available. They're wonderful. Uncommunicative doctors. Sometimes there's some doctors not here tonight who prefer to talk to their computer or focus on their computer rather than the patient. Therapeutic failure, and perhaps it isn't therapeutic failure, perhaps the original expectation of the treatments are unrealistic. And friends who don't visit. And certainly a number of people who say their greatest sadness is not so much that they're confronting their mortality, but rather that friends don't have anything to do with them anymore, because whether it's fear of contagion or whether it's just fear of reality, who would know? So we're looking at a model of total suffering. So as much and all as we might look at an analogue scale that perhaps Jason will talk about shortly, we probably look more at a total suffering model in addition to other measurements that we use for pain assessment. And some of the aspects of suffering and components of palliative care, so pain, physical, psychological, social, cultural and spiritual concerns equal total suffering. And if we have our wonderful multidisciplinary palliative care teams, then we can address those symptoms and have our patients feel supported. Not this slide, but the next one comes from a book written by Professor Michael Nicholas. Last year I had the pleasure of working with him in a research program at Sydney Uni and Royal North Shore Hospital, and the book there that they give to patients is How to Manage Your Pain. And this model of care this microphone's driving me nuts, is about the persistent pain model. So when pain persists, it tends to reduce our activity. It leads to physical deterioration. We can have unhelpful beliefs and thoughts, which also then lead to feeling of depression, helplessness and irritability, sleep loss, repeated treatment failures or perceived as such. If I'm not feeling better, then they've failed. And that also leads to further enhancing these feelings of depression and helplessness. The long-term use of analgesics and anticonvulsants and the side effects that brings with us. And of course your workplace and financial difficulties and the influence of workplace, home and the treatment providers and what we can do to alleviate that perhaps. All of these things lead to excessive or have potential to lead to excessive disability. So that's the model of pain that was promoted by Professor Nicholas and the team at Royal North Shore. And I found it's very, very valuable. So I don't know, some of you have heard me chat on about this before, so I'm just wondering if anyone's put it to use, have anyone tried it? And probably we're doing it subconsciously without looking at this map, but it's a very good guide to our pain assessment and management. We then have a series of validated assessment tools which we should really be adopting and using. And so there's the usual pain score or the analogue scale, and as I've mentioned to many of you before about Dr. Tony Espinay, who's a palliative care pain specialist at Pindara and Gold Coast hospitals, he uses the thought of what does the pain stop you from doing, which is very much in relation to the previous model that I showed you. So sometimes using an analogue scale of 0 to 10 means little to the patient. And I've had certainly a number of patients that 0 to 10 means diddly squat. Whereas if you ask them what it stops them from doing and how they could, what could they do in fact if they didn't have that pain, is a very effective way of working out what their pain, the impact of the pain. The disability score, the depression, anxiety, stress, the fear avoidance beliefs, the pain self-efficacy beliefs and catastrophising are all validated tools that we can take into account when we're assessing pain. So we then look at a current treatment plan of looking at persistent pain, reduced activity, unhelpful beliefs and thoughts, the use of medication, what's happening at the workplace and what's happening at home. And it might be medications and surgery, it might be physio, it might be opioids that I'll leave Jason to discuss. It's important that we explain the medications and encourage the use, the regular use, and gradually perhaps increase if required, but we need a plan. We need to identify, review and modify those unhelpful beliefs and thoughts and talk about the reduced activity and encourage a little more activity. Maintain and review regularly and involve the employer perhaps if that's the point, because many people, I know, I'm sure you've all nursed people who haven't wished to resign from the workplace, and I can't think of many in that situation, and that's, I think, to be encouraged because very often that's their identity. It's so important to retain that for as long as is possible. Involve husbands in the plan. I don't think I'll pursue that one. So the principles of pain management are to believe the patient and help them take responsibility, which probably sounds a little ironic, but it's very, very important that the patient, and it's in accordance with Ottawa Charter, it's having a collaborative approach to patients' pain. Diagnose the cause of pain, why do we have pain, what's causing it. It's very, very important. And plan the management with the patient and hopefully with the carer as well. We need to prevent pain with regular and PRN doses, not just one or t'other. Pain relief never is what PRN stands for in that instance. The ladder, we don't sort of use the ladder very much. In fact, World Health Organisation last year discouraged the use of the ladder, mainly because of the effect of Panadine Forte and such drugs that we used to use as second step. We tend not to do that anymore, but I'll leave that to Jason to talk about. Choose the least invasive route, and that is there because sometimes when people are in hospital there's the thought that perhaps IV or subcut might be better when in fact they are up and about and eating and drinking, and they can in fact manage quite nicely with oral medication. And assess. It doesn't mean I've got a speech impediment, but it is just that important to keep assessing and reassessing. We might have a therapeutic conversation or a PQRST. Tell me about your pain. Where is it? Palliative, what makes it better? Or provocative, what makes it worse? Quality, what's it like? Radiation, does it go anywhere else? Severity, how severe is it? Talk about the analogue scale maybe. I don't always think it's always that applicable, but I know it's something that's on our pain chart and we're sort of meant to use it. And timing, is it there all the time? What brings it on? Some of the causes, particularly in cancer pain, is the infiltration of bone, viscera or nerve by the tumour itself. Perhaps treatment, post-chemo, post-op or radiotherapy. And related pain, constipation, bed sores, mouth ulcers, bowel obstruction, etc., or concurrent arthritis and migraine, which are not going to go away just because someone has a malignancy diagnosed. So we reduce the noxious stimuli to increase the pain threshold. Do we use an opioid and diagnose and treat neuropathic pain? And I think at that time I'll hand over to Jason to talk about opioids and... Yeah? Thank you.
Thank you. Good evening. I think you'd understand my pain standing in front of you, having to give this talk. So, and it's a far cry from being a paramedic to being a palliative care intern. So tonight, as you just heard Virginia speak about the narcotics just form one very small part of the pain management scheme in the palliative care patient. And hopefully tonight we'll talk about the frequently used opioids that we use in the wards, the mechanism of action, their indications, and narcotic conversions, which seems to be so variant in different fields and different faculties. And we'll talk a little bit more about practical considerations. So Virginia just spoke about the WHO letter. It was developed in 1988, and it's probably less used nowadays, especially because step 2 in the palliative care regime is no longer considered an applicable step. We're more likely to use a lower dose opioid in step 2 rather than codeine, and for the different or the variable effects that codeine has. So we'll speak a bit more about codeine a little later. So from an opioid point of view, we look at the different opioids every day, and we look for different effects from it. The most important effect that we're looking in the opioids is the analgesic and CNS depressant effect. We talk about the potential to cause euphoria, and the more important side effects like constipation, and nausea, and drowsiness. Commonly, the opioids that we use in the ward would be morphine, the oral version, Ordine. We generally use a subcut version instead of the IV, and occasionally use Norspan as well. Oxycodone, it's the oral version, and we tend to use fentanyl now for the renal impaired patient. Fentanyl, we use it orally or in the subcut version, and can be used in the transdermal version as well. Our preference, Dr. Berger's preference, is hydromorphone, just because you need a smaller dose to get the same effect, really. So codeine, we speak about codeine. Codeine is converted to morphine in the P450 system, but it's such a polymorphic system, it's so variable. 5 to 10% of patients will not convert it, or it'll convert it in a very low format. You get limited or no benefit out of it. And then you get the other end of the spectrum where there's a few patients that rapidly metabolize it, and you get a very strong effect of the opioid, and that results in unintentional overdose. So we tend to shy away from codeine. We're not really advocates of codeine as such. And then you get that very small percentage of patients who have severe abdominal pain, and it's linked to a spasm of the sphincter vodi. And again, it's contraindicated in liver failure. And as I said, we know it's no longer used in the second step of the WHO ladder. Morphine itself, we generally use Ordine in the oral version. Can be used a subcut and intrathecal. The side effect, the constipation, I think Dr. Berger is a very big advocate of the end that writes the narcotic should write the Aperion. We see it often in the wards, morphine's written up, there's nothing else written up with it, and the patient's complaining of severe abdominal pain or constipation. So I think it's very important to look at that, and when you prescribe the narcotic, consider the Aperion as well. With morphine, it is an unpredictable drug because of the fact that it metabolizes. The metabolites M3G and M6G, there's lots of data on it and write-ups about M3G and M6G. I think the more important bits is that it causes renal failure, it is a dirty metabolite, and that's why we tend to shy away from the drug itself, especially in the renal impaired patients. And there are other options in your renal impaired patients, drugs like fentanyl and hydromorphone, which we'll talk about some more. So we'll talk a little bit about endone, oxycodone. It binds to both the mu and kappa receptors. There's no real significant differences in the efficacy compared to morphine or other receptor agonists. They come in various formats, the 5 milligrams, 10 milligrams, and 20 milligrams short-acting format, and the long-acting format comes in between 5 and 80 milligrams. The new wonder drug is Targin, and some of my colleagues in the ward believe that it's a good drug and others don't, because it specifically binds to the receptors in the gut. It's able to have a greater effect, the naloxone binding to the receptors in the gut, that is. It comes in the maximum dose of 40-20 BD. If you require more, I think it's important to consider the patient carefully, and especially if you're going to use it for patients who have constipation. It has the decreased benefit of decreased constipation. Fentanyl seems to be used quite a bit nowadays. It's a synthetic version of morphine. It's used a lot in patients with renal impairment, and that's because it's said to be less than 10% is renally excreted. However, it's very short-acting, and there's a short duration of action with fentanyl. And it inhibits pain by decreasing the intracellular calcium levels. The transdermal patch is used quite frequently these days, and recently we found that it has a variable effect. Some patients get narcotized quickly, others don't. And it's all dependent on your patient, the amount of adipose tissue that the patient has, and that affects the way it's delivered, the way it's absorbed, and the effect it has. The other problem you will find is that if you use a syringe driver and using fentanyl, very large volumes are required. Recently, we had to use two drivers on a patient because it was a larger volume, and it's more cumbersome. And as I said, with the patches, you need a lot of adipose tissue. The dose is variable, the absorption is variable, and obviously the effect's variable. And we found out that it has metal in it, so you can't use it in an MRI. So the patch, it's not recommended for the opiate-naive patient because of the variability in the effect and the absorption rate. It takes 24 to 48 hours and perhaps sometimes even longer to reach peak serum concentration levels. Generally, we find that if your patient needs about 130 or less of morphine per day, we'd start normally, Dr. Berger recommends to start on the 12.5 micrograms per hour, and you can go up further as your requirements, as the patient's requirements increase. Again, the Norspan patch, it's a partial mu receptor agonist. And the risk with the Norsepan patch is the QT prolongation. It has a limited role in cancer patients, and it requires a change every 7 days. You need compliance with the patch, and you need to make sure that you do change it regularly. You should really start on the lowest dose possible with the opioid naive patients. And again, it contains metal, so you can't use it in the MRI machine. An interesting drug, methadone. It's a one-to-one of the DNL isomer. The D is the potent NMDA inhibitor, which reverses the opioid tolerance. But this drug has a variable half-life, it stays longer in the body. In some patients, your patients can get respiratory depression after 48, 72 hours, up to about 5 to 7 days. So you have the unintentional overdose in these patients. So you've got to be very wary about titrating the methadone. Again, it can cause torsades, but it's very rare. So it is advisable to do a baseline ECG, get a baseline ECG before you start the patient on methadone. So again, with methadone, I think it's important to make sure that you monitor your patients regularly, and the patient's monitored beyond the 48 hours because of the added effect of unintentional overdosing. So narcotic conversions, all the narcotic conversions are converted back to oral. All your drugs are converted back to oral morphine and then converted to the drug of choice that you want. And these conversions, there's a number of apps you can use in the latest technology. ClinicalC is one of the common ones used. If you go to anesthetics, and you can go to the opioid conversion, and it's an easy app to use. There's various other apps around. However, these are the ones that we use at Tweed, and the only reason is because we can remember most of them, and it's easy calculations, really. Ibuprofen 5 times the dose, oxycodone 1.5 times the dose, methadone. This is a variable one. Lots of different people use different calculations. I think we use this because, again, we can remember it. It's easy to calculate. So it's the oral morphine dose divided by 15 plus 15. Okay, and then the Norsepan patch. The conversions are available. The 5 microgram patch is equal to 10 milligrams. Fentanyl's 100 times. And the patches itself, again, it's 25 micrograms. The conversions are all in there. I think it's really important to understand from the patch point of view. It's the adipose tissue, the type of patient you have, the exposure to sunlight, the exposure to heat, the exposure to various factors such as body temperature and whether the patient's sweating, etc. So some practical considerations. I think we start with very short-acting opioid. There's no right or wrong opioid, given the fact, given everything equal, except the patients with renal failure and hepatic failure. You've got to worry about the QT interval being prolonged. Again, this research that I've read, it's very rare, but I guess you got to look out for it. So starting at a low dose in liver failure is important. And I think the most important thing is that it takes about 5 to 6 half-lives to get a steady state, and you got to give the drug a chance to work in the patient. So I think it's important not to just keep changing your drug just to get that effect straight away. Give the patient some time. And avoid alcohol at the time of long-acting doses. And you shouldn't really give alcohol in the first hour. I don't think you want to give the alcohol, but I'm sure the patients would. Again, we can't stress enough, writing the parent is really important. And the constipation is so prevalent in the wards, and I think it's really, really important that if you write a narcotic, consider the parent with it. And again, the side effect profile, I think it's really important to just say to your patients that some of the effects are very transient. It lasts for about 3 to 5 days, and after that, it's it's tolerable. So adding allopurinol or Maxilon in the first few days is really good. In terms of breakthrough pain, I think the way we do it is calculate the total oral dose or the dose for the day in the 24-hour period, divide it and take 1/6 of the dose, and expect it to last for about 4 hours. Titrating the dose against the effect is most important in patients, and giving the breakthrough is really, it's variable in the wards and variable among patients. So I think it's really important to monitor patients carefully, monitor the amount of drug that you're giving, and be wary of the incidental pain. Being variable in your choice with the narcotic is also important. Syringe drivers, we use the syringe driver quite commonly at Tweed. The common drugs that we use that is morphine and clonazepam. Clonazepam seems to be it's not the drug of choice. It's really strong. 1 milligram of clonazepam is equal to plus minus 10 of Medaz. And obviously allopurinol is available as well that we put into the driver. If you're using fentanyl, obviously you need that larger dose, so you may need 2 drivers. And we recommend obviously using clonazepam, and you can use Dex if you get the skin irritation with it. So in summary, prescribing narcotics is dynamic. You need to monitor your patient regularly. You need to look at the patient in an holistic format. And as Virginia said, it's just one part of the pain management in the patient. There's a large variation in the individual patients that you see, and drug metabolism is variable, and as a result, the effect of the drug is variable. Conversion rates are very, very unpredictable, and again, with converting drugs and patients, you see effects within the first few days and some longer. So I'll let Dr. Berger.
I think that's very good. I think the most important part of tonight, though, is probably going to be some interaction afterwards. What say you start thinking of statements or questions now as we're going on? I'll just give you 5 minutes. I was just going to put on my other hat, the other hat as a general practitioner, just because in palliative care we very rarely look at those other issues, and the other issues that I was talking about are those of pharmaceutical drug abuse. And I was just going to take 5 or 10 minutes to talk about that aspect. Pharmaceutical drug abuse is simply the use of narcotics given for the brain reward factor, our drug users. Interestingly, 13% of Americans have admitted to pharmaceutical drug abuse, and there's no reason to think that it's much different here, really. That's 1 in 8 of us, and quite a few of you in the room, isn't there? The pharmaceutical drug abuse, 30% directly, so 30% are coming along to their GPs wanting to get drugs for themselves. 70% are diverting it, and I think we've got to be aware of narcotic diversion in our palliative care patients, and diversion means that we're giving it to others or selling it to others. And anecdotally, a OxyContin 80 milligrams is worth about $50 on the street. So a prescription of 28 tablets is worth $1,400. There's a pretty fair motivation there, isn't there, to come along to your GP and feign pain, and they're pretty good, aren't they? You know, these guys who come in, they don't look like the drug addicts often. They'll often come in a suit and a tie. Prescription drug abuse actually exceeds heroin, ecstasy, hallucinogenics and amphetamine combined. The only drug that exceeds it, obviously, is marijuana and alcohol and tobacco. Patients who work in healthcare are more likely to be prescription drug abusers. There's not 1 in 8 of you, there's even more of you, isn't there? And I guess the bottom line is interesting. Genetically, the individual brain reward is qualitatively and quantitatively different. So, whereas some people are much more likely to become addicted than other people. I've had morphine on one occasion. I thought it was an awful drug. It put me to stop pain, put me to sleep for an hour, and then I woke up with this head that wouldn't shut up. It just, all this rubbish kept going around. So it's not one that gave me a whole lot of dopamine. OxyContin, I think OxyContin's the drug of the moment, isn't it? It's hillbilly heroin. It's, I think sobering, there were 465 OxyContin-related deaths in Australia in 8 years. The marketing has been phenomenal, hasn't it? And the 40 milligram OxyContin tablet, 396 in 1999 to 2000, 396 increased to 208,102 prescriptions in 2000. Now, the marketing thing is interesting, isn't it? In 2005, Purdue Pharma, the drug company in America, was fined $20 million for finding their marketing practice. And in 2007, they were actually fined $600 million for deceptive marketing. I think we do need to realise that drug companies have a commitment to the bottom line for their shareholders. And I know everybody's got their own ideas about Taj and how wonderful it is. I just wonder whether OxyContin's coming off patent, and that's why we're starting to get bombarded with Tarjan. But I'm a cynic. Anyway, I think rather than the drugs pain scale, I think this is a different scale. This is a scale that I have in mind when I see the patient in front of me. Where does this patient sit on this pain scale? And the pain scale 1 to 10. And I think, 8, 9 and 10 is, your cancer pain, your organic pain. 3 to 7, somewhere around that is your neuroplastic or chronic pain or, chronic non-malignant pain kind of people. And there's an enormous number of these people, aren't there? These are the people that we're seeing lots and lots of. I think we can identify, certainly after a while, the 1s and 2s, the drug abuse, the pharmaceutical drug abuse. But where do these overlap, and who is in what category, and where is this person on that pain scale? And I think deciding that decides your approach to that patient. And this one hasn't come up very well at all, but I think this one I would use for everybody in that middle range. And it's a medication use agreement. And I'm sorry that you can't read it, but it's got a couple of statements in it. It's got one statement that I'm under no obligation to supply narcotics to you. It's got a statement that no prescriptions will be supplied over the telephone. No prescriptions will be prescribed at any other time than the regular scheduled appointments. You come and see me today, I give you your prescription, we make the appointment for next time, you've got enough drugs to keep you until then, and then we'll supply the medications. It's got a statement that says that Any lost or stolen prescriptions will require a police report, and this is it's a useful strategy. Patients come in, I've lost it or it was stolen. All right, go and see the police, get them a report and bring me back. And they'll come back with a piece of paper with a number, the name of the policeman and the policeman's phone number on it. And it's very useful then to ring up that policeman and say, look, I've got this patient in front of me. He tells me he's brought my report in. What has he actually told you? And I've had patients who have given different stories to the police and different stories to me. And it's very useful then to say, oh, look, you've lied to the policeman. I can't possibly prescribe any more drugs to you. You don't suggest that they've lied to you. You write the pharmacy name, the pharmacy address. You write which medications, and the medications that I would put on these are all your benzodiazepines and your narcotics. How many tablets a day, how often we're going to see each other. And you get the patient to sign it and you take it away. And that's a very useful. I use then a 3 strikes and you're out policy. Where do you go for support if you decided to treat somebody with chronic pain and you want to give them narcotics? In Queensland, ATODs is extremely useful. Alcohol, tobacco and other drugs are extremely useful. They've got to voluntarily go, but I tell them that I'm not going to prescribe narcotics for them unless I've got some support from somebody else. And ATODs is the most useful person to support me. The pain clinics are other useful places to support you, and Tim Grice down here is quite useful. I find him very useful. New South Wales, I don't know anybody else who's found them useful, but I find that I get no written correspondence back at all. Do you guys get anything? But you've got to. I insist that everybody who's prescribed narcotics for chronic pain goes and sees a psychologist. You need a psychologist involved in this. And if you can't abide by this program, then I'm sorry, I can't prescribe narcotics for you. And that's a useful way around it.